Thank you, Dr. Saad. I would like to thank the organizing committee of the Mega Medical Academy for giving me the chance to be with you tonight. And it's a great pleasure to introduce Professor Dr. Raafat Abdel-Azim. He is my personal professor at Ain Shams University. He's a professor of anesthesia, intensive care, and pain management. The topic today is understanding anesthesia ventilators, part 4. Dr. Raafat, the mic is yours.
Thank you. Thank you, Dr. Tariq. You are most welcome. I'm happy to see you again. Inshallah, hope yes, thank you very much. The previous 3 parts, I will summarize in a few minutes what was the discussion about. Now you know, after attending the previous 3 parts, you know the types of ventilators, what is the respiratory cycle components, and the relationship of the ventilator to the breathing systems, and what is the flow arrangement of basic 2-gas anesthesia machine, and how do the ascending bellows ventilators work, what are the 4 valves operating the ventilator, and we have 3 gases. 2 of them are controlling the operation of the anesthesia ventilator. These are the driving gas, that is pure oxygen under pressure of 4 bar, and the patient gas that is coming into and out of the patient's lungs from the ventilator to the patient, and the reverse direction. And the 3rd gas is the fresh gas flow. We call it fresh because it doesn't go to the patient and come back. It is not circulating. It is what is coming from the outflow of the flow meter, going to the vaporizer and out of the fresh gas outlet. After that, we know the parameters of ventilation or the settings. And part 2, we know now what is inspirator flow rate of the ventilator, and the classification of the ventilators, and what is the interaction between the ventilator and the breathing circuits. The tidal volume is subjected to reduction in each volume, and the addition, reduction by the circuit compliance, affected by the peak inspiratory pressure, and the effect of gas flow is added depending on the inspiratory time and how much is the fresh gas flow adjusted. And I talked about fresh gas flow independent of ventilation to abolish the effect of fresh gas flow added to the tidal volume by fresh gas compensation or fresh gas decoupling. And I discussed in details. In part 3 last time, I described the ventilation cycle and what is controlled ventilation, either volume control or pressure control. And the airway pressure changes in volume controlled ventilation, the peak, the plateau, the end expiratory pressure, and the mean pressure. And what is the effect of resistance and compliance on the airway pressure, and what is time constant, and pressure changes during volume controlled ventilation, and volume changes during pressure controlled ventilation. Today, I will talk about how to monitor the mechanical ventilated patient. To monitor the mechanical ventilated patient, we have to have the screen display. Its display, the display of the screen consists of number of numerical display and graphical display. Numerical display, we have the preset values that we know about the preset values or parameters of ventilation or settings discussed before in detail. We have measured values, what is already given to the patient. It is not exactly, doesn't mean that it is exactly the same values of preset, but it will show what is measured, what is actually given to the patient. And we have numerical display for alarms. I adjust alarms, upper and lower limits of each alarm. Regarding the graphical display, we have 2 types, what is called scalars and what is called loops. Capnography is beyond the scope of this lecture, but I will say something about the CO2 level, of course, because it is the goal of ventilation. The scalars are 3 factors or 3 variables. Each of them is against time. This is the pressure scalar or curve, the flow time scalar or curve, and the volume time. Pressure times means the airway pressure changes over time. This one is flow through time, and volume expiratory and expiratory. Loop means at a certain time we compare or we combine two of these three variables together. Here in the scalars, each one is represented by a graph. But in the loops, two components, the relationship between them is displayed. One for pressure volume. So the point is moving somewhere and coming back. Because it is moving and coming back, that's why it is called loop. So we have loops for pressure volume relationship, loop for volume flow, and loop for pressure flow. You know this before. This is a display of a spontaneously breathing patient. So showing the pressure time curve or scalar. And I said that the pressure is coming slightly negative, -1 or 2, and slightly positive during this one, negative during inspiration, and this one positive during expiration. And the changes are very minimal because this is a patient effort. This is the flow that I will describe later. The flow waveforms are either one of four forms: constant, descending, accelerating, or sinusoidal. What we should know in detail is a constant flow and decelerating flow. Regarding, we don't see all of them in one patient. We see only one type of these inspiratory waveforms according to the mode of ventilation. And in newer forms of anesthesia ventilators, we can modify the way of flow, whatever the mode of ventilation. So usually in all ventilators, we see the constant flow in volume controlled ventilation. Why it is constant? There is what we call flow sensor. The flow sensor senses whether there is flow or not. If there is no flow, it will give a 0 reading all the time, no flow. 0 means no flow. The flow sensor senses the flow and senses its direction and senses its value. So the flow sensor will give a display showing that there is a flow. If the flow is from the ventilator to the patient, it will give a positive wave. If the flow from the patient to the ventilator, it will give a negative wave. So positive wave means it is inspiratory flow. Inspiratory flow starts from the ventilator to the patient. In volume controlled ventilation, the flow is constant. It means that it reaches at once. Once the inspiration starts, it is going up immediately to the maximum or peak inspiratory flow. Then it will be maintained all the time of inspiration at the same value. That's why it's called constant or square waveform. It is a square or rectangle. Then at the end of inspiration, the flow will stop and it will go to 0 here, the start of expiration. So it is a negative wave. This is the negative wave of expiration, reaching the maximum, then going again to the 0 line at the end of expiration. So we can know here the information of having flow during inspiration, and this is the peak inspiratory flow. And the inspiratory time is from this point to this point, and the expiratory time from this point and to this point, and the negative expiration is seen below the 0 line. Here, whatever the form of or the mode of ventilation, the expiration will be in the same way because it is passive. So the display of expiration is always this figure or this line, but the differences in different conditions will depend on the duration of expiration and whether there is some auto-beep or some retention of gas. So or prolonged expiration, it will be different, but it is the same triangle inverted in shape, and it spaces up. If the ventilator flow is monitored during pressure control ventilation, the waveform of inspiration is decelerating during inspiration. Decelerating means it reaches its peak, then immediately, then during the whole inspired time, it will go down, down, down. So it is decelerating. At a certain time, when reaching certain value, it will be cycling to expiration after reaching this value, and the expiration starts. So we are interested now in constant flow and decelerating flow. This is for volume control ventilation, and this one for pressure control ventilation. Each form of flow has its own advantages and disadvantages. This is the actual display showing volume controlled ventilation. This is the airway pressure changes, and this is the flow scalar. And here in flow, we can see that the flow is constant or square form. So this for volume control ventilation. The scalars in volume control ventilation, as I said, there are 3 scalars. This is a flow scalar. This is the airway pressure that I described in detail before. It is peaked here, so it is volume control. And the volume. Volume, I described also before. Volume during inspiration is going up after reaching the maximum, that is the tidal volume. The display here is by milliliters, and here is the peak or the tidal volume. Then expiration is in the opposite direction. In pressure controlled ventilation, the flow is decelerating, and the pressure is constant. That is a preset value. No peak and no plateau pressure in pressure controlled ventilation. And the volume is the same as previously mentioned in volume controlled ventilation. So the difference is like that. This is the volume controlled ventilation scalars, and this one is pressure controlled ventilation scalars. Regarding the loops, I will decide to have loops displayed. So I will choose loop type, whether none or flow volume, pressure volume, and pressure flow. Each time I'll choose only one to be displayed. The most commonly used is the pressure volume loop. I will describe in detail. Before going to mechanical ventilation loops, it is better to understand what is loop during spontaneous breathing or spontaneous ventilation. This is a pressure loop during spontaneous breathing. Here, for loop, we have 2 axes, the horizontal axis for pressure and the vertical axis for volume. So at any time, I should know what is the pressure and what is the volume. The starting point is zero, no breathing. The patient will start to breathe. The direction of movement of the point that is displayed on the monitor is from this point of 0 to the negative side, because the pressure during inspiration is negative. So the point will go to the left, displaying negative pressure. And at the same time, it will go up because of the volume. At any point, it will show what is the pressure and what is the volume. It will go up and left, with more decrease in pressure going to the left, and with more increase in the volume, it will go up. The volume here is the maximum negative inspiratory pressure during spontaneous breathing. That is usually -1 or -2 centimeter water. With increase in the force of breathing, this point will go more to the left, -3, -4, -5, with forceful inspiration. Then it will go again, it will go up until it reaches the maximum volume, that is the tidal volume. This pink area represents inspiration, and the movement of the point or the display will go to the left and up until it reaches the end inspiratory point. Here, we can say that the pressure is again 0 because it decreases during inspiration to -1, and the end of inspiration, it will go to 0. And the tidal volume is the maximum volume reached here on the display. So this point is the end inspiratory pressure, in which the pressure is 0, and the inspiratory point, in which the pressure is 0 and the volume is the tidal volume. Then the expiration will start passively, and the pressure will start to be positive, so it will go to the right, and the volume is coming out of the lung, so the point will go down. Here, the maximum expiratory pressure, that is positive 1 centimeter water in this spontaneous breathing patient, and it will go to the left again because of expiration is finishing at here, and the tidal volume is going out until we reach the end expiratory point, that is of 0 pressure and 0 volume. After understanding, this green area is the expiration. Here, inspiration on the left side and expiration on the right side. When we start mechanical ventilation, of course, we give muscle relaxant, and there is no patient effort, no spontaneous pain. That's why no more negative pressure. No, the display on the left side will disappear completely, and we will see what is happening after giving the patient a muscle relaxant. The starting point here will be 0 pressure and 0 volume. See the red line, that is the positive pressure ventilation, with positive pressure going to the right side and increasing the volume, more to the right, more upwards, until reaching this point. So this point is the peak inspiratory pressure on the horizontal line, and it is the tidal volume on the vertical line. And this is this area is for inspiration. So inspiration starts here from 0 until reaching the peak inspiratory pressure, and the tidal volume 0 pressure going up to the tidal volume. Then expiration starts, and the point moves to the left, and the pressure is going down, and the volume is coming out of the lung into the anesthesia machine or the ventilator, and the point will go down until reaching a 0 point. So this is the movement of the loop, and in the video, it will be displayed clearly. This is the pressure volume. This point, this line is not displayed, but imagine this line from the starting point to the end point. It is the slope of the curve. This slope in this pressure volume loop, we call it the compliance. We call this loop the compliance loop because it is a relationship between pressure and volume, and the steep of this line represents the compliance. If it is steeper going to the left, this means more compliance. More compliance means good volume without much pressure. So when we go to the left side by this line, it is more vertical or more steeper. So it is good compliance with no more high pressure, with less pressure. And if it goes flatter, if it is flatter, going down, more horizontal, it means less compliance because of the high pressure, making it going to the right side, and low volume, making it going down. We will see the normal display in this. This is the volume control because the pressure is peaked and because of the flow is constant. And here we can know the relationship between these displayed numbers. Here's the preset values of tidal volume, respiratory rate, IE, Pmax, PEEP, and more settings. And here the measured values. And here the alarm values, our alarm set. We can see the pressure is peak pressure is 14. So we'll go to the tip here and go to the left side to see what is there. It is 14. And the end expiratory pressure here is not reaching 0. It is +2. So there is PEEP of 2. And the mean, I described the equation before. And this is the flow. The flow is constant or square for volume controlled ventilation. So the PV loop here is displayed on the left side. It will go from starting point is not 0 because there is PEEP, so it will be slightly to the right side. Starting point of 0, pressure is not 0, it is +2. Then it will go up and right with increasing pressure and the volume, and will go again to the left during expiration. The video will display it clearly. Before reaching the video, I will have some correlation. This is 14 of peak, here is 14, and we'll go here, 0 pressure, 40, 20, this is 14 pressure here. So this point, when we go down, it is 14. And here the peak, so this one, the of peaking inspiratory pressure is same here, but the direction, because the display is different, it will be like that. The peak, the end expiratory pressure is displayed in different areas here. It's 2, here 2, and here 2, as I said before. The tidal volume, expired tidal volume, is displayed here. We can see it here also on the loop. When we go to the highest point, when you see what is there, it is what is displayed of 400 value. Now we'll see in this video. See the loop. Again, you see the changes here are the same here. Inspiration going up, inspiration going up, expiration going down, expiration going. Regarding the pressure volume loop during pressure controlled ventilation, in pressure controlled ventilation, you see the pressure scalar of constant pressure here, or the preset value of pressure, or the pressure set. Here, we set the pressure at 11 centimeter water. We set it there to have the tidal volume of this. So this pressure is the maximum pressure reached. We don't give its name, the name of peak, because it's not peaked. We don't say maximum because it is a preset value. So this is a peak. We can say peak pressure, but it is actually it is a preset value. The peak pressure is not peaked. It is constant during pressure control ventilation. And when we go to the loop, we can see that the starting point is 3. So it is 3 on the horizontal line of pressure. It will go up to the right, because of pressure, and up because of volume. Then it will reach its peak, or its preset value, or the inspiratory pressure value, and it will be kept constant. So this vertical line is constant, exactly the same as the horizontal line here in the pressure scalar. So no more going to the right side. It will be constant. The pressure is constant. Only the volume is going up. It is going up because of the building volume until reaching the end inspiratory point, displaying the tidal volume of 440 or 450. It will go to the left during expiration, and again to the starting point. You see here the flow is decelerating because it is pressure controlled ventilation. So this is the pressure volume loop during volume controlled ventilation. You see its shape. It is peaked, and this is the pressure volume loop during pressure controlled ventilation, and it is flat here for pressure value, and the other description I described already. So this is the difference in shape according to the mode of ventilation, difference in shape of the loop. Regarding the flow, I am talking now about the normal loops. Of course, these loops need more than 2 or 3 more lectures to describe the abnormalities. But now I am talking about the normal loops. For the normal loop of flow volume during volume controlled ventilation. So The flow displayed on the vertical line and the volume displayed on the horizontal line. So whenever move on the horizontal line, it is the volume change, and the vertical line, it is the flow change. We start here at the 0 point of no flow and no volume. This is the start of inspiration. Starting inspiration here means going to the left for volume building and going up for flow changes. So the point starts to go up with starting flow, will go to the left with building volume inside this is the inspiration, until reaching the maximum flow and until reaching the tidal volume given. So no flow will stop, and the flow will be reversed from the patient to the ventilator. So it is in the negative direction with going down, and the volume will go again to the right side because it's coming out of the patient's lungs until reaching the 0 point of end expiration. So this is the flow volume loop showing positive wave in inspiration and negative wave in expiration, positive and negative in flow. And it is going to the left side from 0 until reaching the tidal volume here of almost 400 or 375, then going back to 0 at the end of expiration. This is the flow volume loop during volume control ventilation. See what is there. Flow volume. So this is the volume here displayed in numerical display. You can see it here at the point maximum reached, starting from 0 to its end. Here it is 375 milliliter. And the flow, we can see the constant flow here, reaching from 0 flow to its peak or peak inspirated flow. This value will be displayed here at the top of the display on the loop on the left side. It is the end inspiratory point of having peak inspiratory flow and tidal volume. And the reverse will occur during expiration. For the flow volume loop during pressure controlled ventilation, as I said before, the flow is decelerating. It has a peak and it is going down during inspiration until reaching the point of cycling. During pressure controlled ventilation, you can see the volume here. The flow is going up until reaching its peak. Then it is decelerating, not constant like before in volume control, until reaching the end inspirated point. And the reverse will occur with no change, no difference between volume control and pressure control during expiration because it is passive. You see now the difference. Here is the flow volume loop during volume control ventilation. And this is the flow volume loop during pressure control ventilation. Regarding the third type of loops, that is the pressure flow loop. So here in volume control ventilation, we can see the pressure on the horizontal line and the flow on the vertical line. Of course, the pressure will go from this point, starting point to the left, and the starting point here is not 0 because there is a bead. So it starts from 2, and it will go to the left side on building the pressure until it reaches its maximum. It goes up because of the flow. You can see here the flow is constant because it is volume controlled ventilation, and here also it is constant in the loop. So it will go up for the flow, go to the left because of the pressure. At the end of inspiration, it will go down to the 0 point of flow, and it is the end point of pressure, that is the peak pressure. Here, the displayed pressure of 16 will be seen here on the horizontal line. At this end point, we reach the peak inspirated pressure and no flow that stops at the end of inspiration. Then the pressure will go to the left to approximate 0 or to reach the end expiratory pressure, and the flow in the opposite direction because of the negative flow during expiration. So this is a pressure flow curve during volume controlled ventilation. Pressure flow loop, sorry. Pressure flow loop. I described this already. The points seen here and then in this graphical display of scalars will be seen on the loop display. The pressure flow loop during pressure controlled ventilation, as I said, the pressure is constant, no peak, no plateau. And here it will be seen reaching the peak pressure, it will be constant here. This vertical line is the same horizontal line in the pressure scalar. And the flow reaches its maximum here, exactly the same as seen on the flow display. And the pressure change and the flow change during expiration are almost the same as in the flow graph. So I described how to monitor the mechanical ventilated patient, apart from ABG and other forms of monitoring, how to monitor the patient on the ventilator by seeing or observing the numerical display and the graphical display. The graphical display is by 3 types of scalars that are pressure, volume, and flow. And the loops are the relationship between 2 of these variables in each time I choose a type of the loop, whether it is pressure volume, pressure flow, or volume flow. Why do we ventilate patients? We ventilate patients to achieve a goal. What is the goal of ventilation? It's to provide adequate minute alveolar ventilation, adequate, that is necessary to maintain the desired PCO2. When I give adequate ventilation to give the desired PCO2, this is now I achieve the goal. And to decrease the side effects. What are the side effects? Because of post pressure ventilation, the intrathoracic pressure increases. This increase will have some hazards or some side effects. So I have to keep adequate ventilation without having much of these hazards of high intrathoracic pressure. What is adequate ventilation? Please focus on this point. Consider that we want the PCO2 of 40 millimeter mercury. 40 millimeter mercury is the normal. Of course, this is an range from say 36 to 44. Let us consider it 40. 40 millimeter mercury is the partial pressure of carbon dioxide. It is present with other gases to represent the total of pressure of 670, that is the atmospheric pressure. So carbon dioxide is 40 millimeter mercury in 760. It represents 5.3% of the total pressure. This is the partial pressure of carbon dioxide. This 5.3% is derived by this equation, 40 over 760, it is 5.3% or 0.053. So we can have the capnograph or the end-tidal carbon dioxide represented by millimeter mercury or kilopascal or percent. When we select the display to be in percent, it will be 5.3 at the end of expiration if it is 40 millimeter mercury actually. Let us go back to this point of how to calculate the adequate ventilation. We want to keep this relationship of 40 millimeter mercury in 760. The relationship of carbon dioxide to the total is 5.3. The normal carbon dioxide production in healthy individual is 200 milliliter per minute. That is 0.2 liter per minute. This 0.2 liters per minute, represented here by this red point, is in a minute volume of the represented by the light blue circle. So we want to keep the relationship of 0.2 liter in something that is the minute volume. How to calculate the minute volume? The minute volume required is the one to keep the relationship between 0.2 to the minute volume, exactly as the relationship between 40 and 760. So we divide 40 by 760, that is 5.3%. Go to the opposite side, we want to keep the relationship between 0.2 with the unknown minute volume. By cross multiplication, we reach this number of 3.8 liter per minute. So the relationship between 0.2 liter per minute, that is carbon dioxide production, in relation to the total minute volume of 3.8 liter per minute, this one keeps the relationship of 40 millimeter mercury to the total pressures. So we need the minute volume in an adult patient with normal carbon dioxide production of 0.2 liter per minute. To keep the CO2 at 40, we need 3.8 liter per minute. But we have to add the dead space because it is not sharing in gas exchange. So it is understood now that the minute volume should be 3.8 liter per minute plus the dead space. The dead space normally is 1 milliliter per pound for in countries that we can measure the weight in pound, or it is 2.2 milliliter per kilogram because 1 kilogram represents 2.2 pounds. So the normal dead space is 2.2 milliliter per kilogram. So for average adult patient of 70 kilogram, it is 1.454 pound, or I mean the weight. So it is 2.2 times 70, it is about 150 milliliter. This is in one tidal volume. Suppose the frequency of that respiratory rate is 10. So in 1 minute, we need 0.15 liters times 10, that is the frequency. It equals 1.5 liter per minute. Go back to the previous slide. We need the minute volume to be 3.8 liter per minute to get rid of the carbon dioxide produced in 1 minute, and to add 1.5 liter for the dead space. So the required minute volume equals 3.8 liters per minute for carbon dioxide produced and 1.5 liter per minute for the dead space, and the total is 5.3 per liter. You take this 5.3 and give the tidal volume and the respiratory rate multiplied to get this 5.3 liter. Increasing the minute volume is required for patients who have more dead space or who have more carbon dioxide production. Carbon dioxide production is more in thyrotoxic patients, in feverish patients, during pregnancy, in certain conditions of sepsis, and so whenever we have carbon dioxide more than normally produced, so we need to increase the minute volume. Go now to the dead space to have some information. We have two types of dead space, that is physiological and anatomical, and the third one is alveolar. We talk about the physiological dead space that shares in ventilation. Physiological dead space equals the anatomical. Anatomical dead space is the conducting airways. Anatomical dead space is the airway not contributing in the gas exchange. It is only the conducting airway. And as I said before, it is 150 milliliter in a 70 kilogram adult. Plus the alveolar. What is alveolar dead space? The alveolar dead space is created when some alveoli that are not perfused, when they are ventilated. This value is negligible in health, but increases in disease. In diseases in which some alveoli are not perfused, but we ventilate with mechanical ventilation. So it will create, by having these alveoli that are not perfused and ventilated, it will create alveolar dead space. It should be added to the anatomical dead space to have the physiological. When intubating the patient, the dead space will decrease by a value that may reach about 6% if we tracheostomize the patient. In tracheostomized patients, the value will be almost 60% because some part will be subtracted. Go again to the equation. carbon dioxide and this space, when they are stable, the relationship between minute volume and PCO2 is an inverse relationship. This inverse relationship means the minute volume is inversely proportional to the PCO2. This means that if we multiply the minute volume at a certain time to multiply by the PCO2 at the same time, it will be constant. So when we change the volume from volume 1, the minute volume, from volume 1 to volume 2, the PCO2 will change from PCO2 1 to PCO2. So now we have this patient ventilated, having a certain minute volume and a certain PCO2. I want to change the PCO2 to another value, either increase or decrease. So I will utilize this equation to know what will we do for the tidal volume, the minute volume, for the minute volume, to change, to have the PCO2 change it to the P2 value. For example, if the PCO2 is 50 millimeter mercury with a minute volume of 5 liters per minute, I need to increase the minute volume to 7 liters per minute to have the PCO2 decrease from 50 to 36 by utilizing or performing this equation. 50 times 4 times 5 equals 7 times 36. Now we go to some manipulation of the equation. I said that the minute volume is tidal volume times frequency. But what to change? What to change? It is it the tidal volume or the rate? Let us consider that we have a patient having tidal volume of 500 milliliter, and the rate is 10 per minute. So the minute volume is 500 times 10, it is 5,000 milliliter or 5 liter. If we have the tidal volume and double the rate, we have the same effect. That is 500 times 10 per minute equal 250 times 20. It is simple. But go to more detail and subtract the dead space. Take this one, 500 minus the dead space. This means 500 minus 150. If you multiply, this will be 350 times 10, it will give 3.5 liter. Again, go to the other one, 250 times 20. 250 minus 150, it will be 100. Times 220, it will be 2000. So see the effect of dead space here, it will change much the product. So consider the dead space. That's why we say always that there is a minimum effective tidal volume, that is, don't go down below double the dead space. The dead space is 2.2 liter per minute. When you need to decrease the tidal volume, as in cases of ARDS, pulmonary edema, or any case of reduced compliance, as I said before, we need to decrease the tidal volume. Decrease, but not less than 4.4 milliliter per minute. That is the double of the dead space. The side effects that we should consider and try to avoid, these side effects related to the post-pressure ventilation, high intrathoracic pressure. It will compress the veins and increase the pressure inside the chest, so the venous return will decrease and will lead to a reduction in the diastolic volume and a reduction in cardiac output. Also, the high post-pressure ventilation will increase the pulmonary vascular resistance and decrease also in cardiac output. When we apply post-pressure ventilation with increasing intrathoracic pressure, this one represents the alveolus and this one represents pulmonary artery pressure. If the alveolar pressure is more than pulmonary artery pressure, this will compress the artery, so less perfusion with good ventilation, and it will increase or create a dead space. Or the effects of high or the value of mean airway pressure should be considered to have a low mean airway pressure while maintaining adequate ventilation and oxygenation. Of course, the mean pressure will give a good oxygenation, but it will have negative effects on the cardiovascular system. Now, let us have some applications of what was told before. During volume controlled ventilation, this is a display of the airway pressure changes, and this one is the flow changes, square flow, and this one is the volume change. The pink squares represent the time of inspiration, the light blue represents the time of expiration. Now, if we create a pause here, this pause will be subtracted from the inspiratory time, or it is part of inspiratory time, and inspiratory time consists of the inspiratory flow time and the pause time. Now, let us go to have some changes in these settings. We have this tidal volume here in the volume time display, volume time scalar. This is the inspiratory volume changes reaching the tidal volume, and this is the expiratory. So the peak is the tidal volume. Consider this one is, we call it tidal volume 1. Now, which will change, will do some change. The flow means volume per time. So the flow here equals tidal volume in this case divided by inspiratory time in this case. You see the inspiratory time is 2 squares here, and the volume here is 1, 2, 3, 4 squares. The flow is volume divided by time. If we increase or decrease the tidal volume, we'll keep the rate constant, we'll keep the IA ratio constant, 1 to 2 here in this example, but we'll increase or decrease the tidal volume. By increasing the tidal volume, so we'll take this point up from the light green one of the previous graph to the dark green one up. So this is a new tidal volume. The tidal volume is higher than the previous one. It changes the tidal volume while keeping the time constant. This means that the equation of dividing the tidal volume over the time will have higher flow rate. So by keeping the inspiratory time constant, keeping IA ratio constant means keeping inspiratory time constant. By increasing the tidal volume, the flow is higher. And by decreasing the tidal volume, the flow is lower. Of course, we keep changing some ventilator settings while not thinking about the other factors, what will happen. So consider that when you change the tidal volume, either by increasing or decreasing, you will affect the flow. Here it is steeper, and this one is flatter, slower flow. Keep the tidal volume constant, but decrease the inspiratory time. Go to the left. This is a light green curve on the previous one. When you go to the left, but at the same horizontal line, so the same tidal volume, but shorter inspiration. Shorter inspiration means shorter time, means when you divide the volume over this shorter time, the flow is higher. So whenever we reduce the inspiratory time, this means increasing the inspiratory flow rate, and the reverse will occur with increasing the inspiratory time. When we create pause, this means that this will affect the duration of inspiratory flow time by making it shorter. This is the light green one of the previous one. When we go to the left side, that means we increase the duration of the inspiratory pause. So the flow will be steeper. So it will be higher. This is the volume time curve. This one is inspirator time from this point to this point, and the expirator time from this point to this point. The maximum here is the tidal volume, and this line represents the inspiration, and the flow represented by this slope is the time per tidal volume divided by inspirator time, and the expiratory flow rate is the tidal volume divided by expiratory time from this point to this point. Now consider changes. 1 change in this direction, 2 in this direction, 3, 4, 5, 6. Let us take the first change. Changing the tidal volume, keeping the tidal volume constant and going to the left side means reduction in the inspiratory time. By reduction in the mean expiratory flow rate, inspiratory flow rate will be constant. The mean means from this point to this point, and will make some collision. But the inspiratory flow rate will be higher, the peak. So the peak is high because of the slope will be more vertical or steeper. The IA ratio will change because we shorten the inspiration and prolong the expiration. So the mean expiratory flow rate will be lower because it has more time. So when we decrease the inspiratory time, the expiratory time is increased. And the effect of flow change will be reversed on the expiration. In inspiration, it will be higher and expiration will be lower. Go to point 3, increasing the tidal volume. I described before, will have the same, these effects on the bigger tidal volume or smaller tidal volume, and the flow rate here in inspiratory and expiratory will increase, and the flow rates here in inspiratory and expiratory will be decreased by changing the tidal volume while keeping the IA ratio constant. Increasing the tidal volume but keeping the flow constant because we are moving on the same line. Constant flow, but increasing the tidal volume. Here, the constant, the flow will be constant, but because we move to the right side, so the inspiratory time will be higher, longer, and expiratory time will be longer. And you know now the effects on the flow rates of each of inspiration and expiration. And this one is 4 is the reverse of 1. And you know now exactly the effects of changing this point to the right side by increasing inspiratory time and decreasing the expiratory time. Here we have point number 5, that is moving the end expiratory time to the right side. This means that if we keep frequency at a fixed IA ratio, if we decrease the frequency because we lengthened this line from this point to this point in the previous example, we lengthened it. Lengthening means increasing the respiratory cycle time. Increasing the respiratory cycle time means reduction in frequency. But if we keep the IA ratio constant, this will lead to increase in both inspiratory and expiratory times, and the mean flow during expiration will be less. Moving to this point to the left side to be moved to the point number 6 means the reverse of these effects. What will happen on creating a pause in volume controlled ventilation? This effect will be seen by this horizontal line of pause and pressure and volume curve. It has no clinical effect because the volume is kept constant here. But in flow and pressure, we'll see the change described early in detail. And we'll have, now we will separate, we have the flow waves of during inspiration and expiration will be separated by a 0 line, that is no flow line or pause time. During expiration, pressure control or pressure oriented ventilation, we don't apply pause routinely, but we apply it only to know the pause pressure. So if we want to know the pause pressure, we'll apply pause to see its effects. Here, the decelerating flow during expiration, and expiration is constant, and there is, I mean constant, it is the same shape, whatever the mode of ventilation, and this is the pause time. Of course, everybody knows why we change the IA ratio. The inspiratory time is needed for oxygenation. Expiratory time is needed for carbon dioxide removal and obstructive airway diseases. So we'll increase this portion during expiration, this one, for more carbon dioxide removal, or to give more time for expiration if there is expiratory flow obstruction. The reverse will happen if we need to ventilate a patient with hypoxia. We will apply what is called inverse ratio ventilation. And this is one of the tools needed during management of hypoxic patient. Will shorten the expiratory time and increase the length of inspiration to reach the ratio of 1:1 or 1:2, 1:1 or 2:1 or 3:1. Instead of the normal ratio of 1:2. So we can make it 1:1 or 2:1 or 3:1 according to the degree of hypoxia. Of course, the management of hypoxia or hypoxic patient, we have many tools to manage the patient. Of course, after detecting the ventilating both sides, after removal of secretions, removal of the cause of, or treating the cause of hypoxia, we increase the respired oxygen concentration, but not more than 60%, more than 24 hours. I'm talking now in ICU, but in anesthesia ventilators, of course, we usually we don't ventilate patients more than 24 hours, but avoid giving 100% because of atelectasis will happen once we start anesthesia. To avoid absorption of atelectasis, we don't give too much oxygen. Now we issued 60%, and we need more help. The more help will be applied through application of PEEP, and through application of inverse ratio ventilation, and through application of inspiratory pause. Inspiratory pause means we'll keep the lungs inflated for a longer time. Instead of having the curve like that at the end of inspiration, then expiration, we will have some point of more time of having the lung inflated. So it is inspiratory pause or inflation hold. Because I said before, during this hold or pause, there is no flow, and there is redistribution of gas into the alveoli from the high pressure to the lower pressure alveoli, or from the less compliant to the more compliant. This will reduce the pressure. At this point of no flow, there is no resistance and no pressure. It is only redistribution. And in healthy individuals, it has no visible effect, but it is more important in patients with some diseases like ARDS. Inspiratory pause will increase the the time of inflation during inspiration, and this will optimize the ventilation perfusion matching. And it's increasing inspiratory pause time during this will lead to more gas distribution, improving the PO2, will decrease the dead space and the relationship of dead space to tidal volume ratio. It will help in decrease of PC2 and ARDS, utilizing less tidal volumes, and it prevents higher PCO2. Low plateau pressure, let us go to this down. It improves oxygenation in post-surgical patients, also not only the ARDS patients. Inspiratory pause, actually in clinical practice in healthy individuals, is not recommended in clinical practice except to check the P plateau and to measure the static compliance. In inspiratory in volume controlled ventilation, you can see the pause pressure, or sometimes it is not visible. If it is not visible and you want to measure the plateau pressure to monitor a patient who is changing compliance, so you create pause by pressing the inspiratory hold or pause button and adjusting its duration or its percent to 10, 20, 30% to see it and see the value and the duration. Now you can know the pulse pressure and you can calculate the compliance. Also, in pressure controlled ventilation, it is always not seen. So during pressure controlled ventilation, if you want to do the compliance and you know to want the pause pressure, you create pause just to measure. But usually in clinical practice, it has no value in healthy individuals. Dr. Yasser, I hope I answered your questions that was before. Now we will stop at this point because the time is running. It is almost 1 hour. Thank you.
Dr. Raafat for this very informative session. And I would like to thank the attendees for their precious time and the panelists. And we would like to announce that the next session for Dr. Raafat will be on 5th of July. Inshallah.